Alright, sorry, I lied. There are two more after this one and the next one. Anyways, I'm sure most of you are aware of sudden infant death syndrome, or SIDS. There's a big push called Back to Sleep, which proved successful in blunting the rates of SIDS as babies sleeping supine have better arousal function, which is suspected to be the main culprit, although we're really not sure. There are a few differences between SIDS and something called primary sleep apnea of infancy, although we aren't really sure what the actual mechanism or some of the parts that causes SIDS. For primary sleep apnea of infancy, we're talking about prolonged central, mixed, or obstructive apneas or hypopneas associated with physiological compromise, meaning they aren't growing like they should or aren't getting the rest and sleep they need to properly develop. It culminates into hypoxemia, bradycardia, and occasionally the need for stimulation or resuscitation. In premature infants, there is more of a central component to the apneas, causing them to be mixed. But with older and larger infants, they tend to have pure central events. There are a few theories as to why this happens. First, immaturity of the brainstem and respiratory sensors may have chemoreceptor or mechanoreceptor response delays. The upper airway reflexes may not be sufficient to allow easy breathing. There are other medical conditions like anemia, chronic infection, hypoxemia, metabolic disturbances, GERD, and drugs can all cause depression of the respiratory centers in the brain. Commonly, the more mature the infant, the less likely they are to have apnea. There is a developmental delay in the respiratory control center associated with prematurity. Normally, the number of respiratory events increases during active sleep. There are two classifications for primary sleep apnea, and they both have to do with age. Apneas of prematurity are seen in children younger than 37 weeks conceptual age, and apneas of infancy are seen when the conceptual age is 37 weeks or older. Differential diagnoses involve considering what else may be happening with the patient if it's not primary sleep apnea of infancy. Periodic breathing in young infants is considered benign, which is not harmful. Periodic breathing is when there are at least 3 central apneas lasting at least 3 seconds without no more than 20 seconds of normal breathing. Normal respiratory pauses are short central events, and they're normal, especially during sleep, movement, and size. There are several characteristics that may predispose an infant to primary sleep apnea, namely acid reflux, which we know can cause edema in the airway muscles, anemia, anesthesia, which causes the central nervous system to lessen its activity. Drugs like benzodiazepines or opioids can suppress the central nervous system. Infections, lung disease, metabolic disorders, which are problems with nutrient digestion and absorption like diabetes. Neurological problems and seizure activity may also affect respiratory systems of the brain, causing an arousal dysfunction or just plain apneas. Small airways are susceptible to obstruction as well. ALTEs are apparent life-threatening events like serious trauma, like a car accident. Sometimes sickle cell patients have crises which are life-threatening. Meningitis can also be life-threatening, which would fall under the infection and ALTE categories. SIDS is also a characteristic of primary apnea. Although SIDS is a characteristic of primary sleep apnea of infancy, it is not the other way around, which is interesting. This means primary sleep apnea of infancy does not cause SIDS. It's a different anatomical mechanism. These central events in infancy typically resolve after 40 weeks conceptual age. Alright, SIDS is sudden infant death syndrome. It involves the sudden, unexplained death of an infant younger than 1 year old. They usually expire during sleep, and it's a leading cause of death in infants under 1 year old. About 40% of infant deaths are due to SIDS, which translates to approximately 7,000 in the United States per year. The cause is unknown, but autopsies show evidence of repeated episodes of hypoxia or low oxygen levels. One theory explains that abnormalities in several parts of the brainstem may be to blame. Some structures in the brainstem of SIDS infants have been shown to be less likely, uh, have been found to be less likely to process the neurotransmitter serotonin than infants who died of other causes. One study found that SIDS victims were found to have decreased binding of serotonin in the nucleus raphe obscurus, which is part of the brain that is linked to the arcuate nucleus and in 4 other regions. These regions are thought to play a critical role in regulating breathing, heart rate, body temperature, and arousal, 4 things that are huge in SIDS patients. However, it's unfortunately very hard to tell the difference between SIDS and intentional suffocation, which is homicide. There was a person, Juanetta Hoyt, and she was convicted of suffocating 5 of her 6 children, and that case has served for crucial data for SIDS research to discern the difference between mostly pathological, like SIDS, and homicidal outcomes like suffocation. The mothers of SIDS infants are known to show several common characteristics, including mothers younger than 20 years old, low economic status or poverty, ethnicity, or those of African American, Native American, or Native Alaskan descent. Also, it should be noted here that ethnicity itself is not to blame for these characteristics. It is a commonality between these ethnicities. Specifically, these groups of people have been more recently historically enslaved, run out of their native land by violent white immigrants, or oppressed by their cultures. Also, there's an increased risk with history of previous fetal loss, cigarette smoking, drug abuse, illness during pregnancy, and inadequate prenatal care. Cigarettes are known to cause perinatal defects like low birth weight, and drug abuse has been studied to show an impaired chemoreceptor response to carbon dioxide. Illnesses during pregnancy can disrupt fetal development, as well as poor prenatal care, which can cause insufficient nutrition during growth. Just like primary sleep apnea of infancy, there are certain characteristics that predispose infants to SIDS. These include being a boy, male, infants who are born prematurely, and those who are born at a low birth weight, common for infants whose mothers smoked during pregnancy. Gestational age is usually considered to be the age of an embryo or fetus or newborn infant from the first day of the woman's last menstrual period. This standard system of counting the progression of pregnancy starts approximately 2 weeks before fertilization takes place. It does not itself constitute the beginning of pregnancy. The APGAR test is a test performed twice, shortly after birth, to take a quick examination of the vital signs of the infant. Low APGAR scores are indicative of SIDS patients. If the patient has to be resuscitated either with oxygen or ventilation, that has been documented to be a SIDS factor. It's probably not the ventilation or oxygen that causes SIDS, it's the fact that the patient required it that is the indicator. Even though they are higher risk if they have a sibling who was a SIDS victim, there is no true evidence of a genetic factor. Here's how the APGAR score works. The vital signs examined include their appearance or skin color, their heart rate, their reflexes, their muscle tone, and their breathing. The score is collected on the different characteristics. There are positive, moderate, and negative scores, 2 to 0 respectively. The higher the score, the healthier the patient seems. Skin's color is specifically looking for if babies are properly oxygenated. If the skin is blue or has blue spots, that's a sign of poor oxygenation, or cyanosis from hypoxia. Cyanosis is blue skin, hypoxia is low oxygen. If the heart rate is absent or below 100 beats per minute, that is abnormal. If the patient has no response to stimulus like bright light, closing their eyes, or doesn't have a strong cry, that is abnormal. They should also be scrunched up like a frog hanging out sitting, bringing their legs and arms to the midline. If they are limp, only demonstrating some muscle movement, that gets a lower score. Finally, their respirations should be strong. If there are no respirations or they're weak and irregular, that is a lower score. These exams are performed at 1 and 5 minutes after birth and may be repeated later if the score remains low. Scores below 3 are generally regarded as critically low. 4 to 6 is fairly low, and over 7 is generally normal. A low score on the 1-minute test may show that the neonate requires medical attention, but is not necessarily an indication that there will be long-term problems, particularly if there is an improvement by the stage of the 5-minute test. If the APGAR score remains below 3 at later times, such as 10, 15, or 30 minutes, there is a risk that the child will suffer long-term neurological damage because of the oxygen deficiency. There is also a small but significant increase of the risk of cerebral palsy. However, the purpose of the APGAR test is to determine quickly whether a newborn needs immediately medical care. It was not designed to make long-term predictions on a child's health. Contrary to popular opinion, the APGAR score is no longer used to decide if a neonate requires resuscitation. That decision is based on an emergency assessment of airway, breathing, and circulation, ABC. Believe it or not, it is not uncommon for infants to need a little respiratory help right out of the oven. The name APGAR comes from the acronym for appearance, pulse, grimace, activity, and respiration. Some instances further enhance the likelihood of SIDS. Infants who are under 6 months of age are most likely to suffer from SIDS, peaking between 1 and 3 months. The peak also occurs during winter, between the months of October to March. So there's something about possibly overheating a room or the patients being too warm that affects the respiratory system when you're sleeping. Sometimes there is a mild illness in the week preceding death, that which usually occurs while asleep, and most commonly while sleeping in the prone position. It's thought that SIDS patients don't respond to carbon dioxide retention, and sleeping prone can exacerbate the rebreathing. The patients also have a history of apparent life-threatening events. There are many preventative measures to help reduce the rate of SIDS. When children sleep supine, they are more likely to arouse more frequently, which is thought to be one of the causes of SIDS, a weak arousal mechanism. The patient's parents should be trained in CPR, and a monitor should be used to track the infant's respiratory and heart rate. Knowing the things that can cause SIDS and matching those with expected parents can proactively prepare the parents for signs of SIDS, and they can intervene when necessary. Just knowing about it can be enough to make a big difference. There should be no loose items in the sleeping area, including pillows, blankets, toys, or stuffed animals. Anything that can cover the face can cause problems. A firm mattress is also desirable to keep the patient supine. Again, in the winter months when SIDS happens more, don't overheat the room. For whatever reason, sleeping hot can cause SIDS. Breastfeeding is also proven to be good for babies by building their immunity against illness and infections. The cause between breastfeeding and why it works for staving off SIDS is unknown, but the trend is there, and it's less common for breastfed babies to die from SIDS. Here's a little bit more information about overheating. Temperature has been shown to affect the stability of the respiratory system, so it would make sense that SIDS occurs during winter when you blast the heat in the house. You typically lose more heat from your front side than your back side. That's why you retain more heat when you sleep on your stomach or prone, thus the push for back to sleep. It also takes more stimulation to arouse a person when their temperature is higher. Research has shown that slight increases in room temperature have resulted in apneas in premature infants. Although the reasons for SIDS and primary sleep apnea of infancy is poorly understood, there are some treatments that could assist in preventing or helping symptoms. Although stimulants can keep you awake, they also increase the blood flow and respiratory rate and may work on the respiratory center when the patient is sleeping. Methylxanthines include a drug called theophylline, which has been shown to improve sleep-related breathing disorders. It relaxes the airway, stimulates the respiratory center, and increases the velocity of the diaphragmatic movements. Bronchodilators are commonly used in asthmatic patients to prevent nighttime asthma attacks and coughing, which can cause awakenings. Steroids can also be used to decrease inflammation from infection and help lungs mature and grow faster. All right, now we have one left.